The patient is named Charlotte. She gave me permission to use her likeness. She's a 52-year-old Downs patient, very active, helps manage her group home. Saw me 2 years prior to surgery with pain and a little bit of radiculopathy, but we decided to just follow her. But then came in a couple of years later because her balance and hand function had gotten so poor that she wasn't able to keep up with her chores at the group home. So this is the MRI that she had in August of 2020 when I first met her. And then in June of 2021, just 10 months later, you can see that there's been a significant progression, both in terms of the retrolisthesis at 3-4 and the cord compression there, but also with the basilar invagination. And you can see that the interval between her odontoid and the basion went from over a centimeter to essentially nothing, and then the medullary kinking that resulted, which probably led to most of her severe myelopathy symptoms. And then finally, just a CT scan that again shows the proximity of the odontoid to the basion. So I think a lot of folks are probably still in the vendor room, but when you see a case like this, classic sort of basilar invagination, I don't know if anybody just wants to kind of speak up, but do you generally do C1 into the subaxial spine? Do you extend to the occiput? Are there...
Honey, I wanted to start in terms of her neural exam. You say she was losing dexterity, kind of myopathic, and how do you, I think about the cervical medullary junction, maybe an angle of about 130 degrees, more acute than that could be problematic.
Yeah.
But how do you really define where the pathology is coming from? Like at the cervical medullary junction, would you expect more cranial nerve problems versus?
So she didn't have any, and certainly you can get hypoglossal issues or any of the lower cranial nerves.